Okay, so hello everyone. It's time for our webinar of the day, and before like this is not the last webinar, is that before the last webinar. So I'm happy that we had a very interesting month for IADS Webinar European Webinar Month series. And if it's your first time to attend our webinars, I'm Mariam. I'm the IADS Vice President of Science and Research. And today is a very, very special webinar because we have a special guest, Professor Dr. Martin. He is from Czech Republic, Czechia. And I love Peru. And I'm so excited for his topic today. So, on behalf of IADS, I would like to thank him so much for giving us from his time and effort. I know that you were in a surgery now, so you freed up your time for IADS and for IADS students. So thank you so much for that. Appreciating it so much. And we can't wait to know more about your expertise, about your experience. So I will not take more from that. I will give the floor for Yana. So the floor is yours, Yana.
Thank you, Mariam, for the introduction. Hello, guys. My name is Jana Panachova. I'm from Czech Republic as well as the speaker, and I'm the General Secretary for SCAR Committee in IADS. And I'm very happy that today the speaker, he can represent our country, Czech Republic. So I would like to also thank you, Doctor, for representing our country and dental society. So we really appreciate it. Thank you very much for taking the chance to speak for us. Thank you. So I would like to pass the word to our webinar coordinator, Mahanar. So please take this lead.
Thank you, Anna. First of all, thank you everyone for attending today. I'm really, really happy to see you all again and see your names here. And I have to thank my beautiful team, honestly, starting from Mariam to Anna to Pek, who's not here with us, but and to Yasha, the European ambassador, honestly, and by far the most I have to thank Dr. Martin for this for accepting our invitation and gladly taking the lead for today in our webinar. So today, Dr. Martin will speak about the soft tissue management around teeth, an introduction to clinical applications, which he just, as Mariam just said, he did have a surgery right now. He just finished it off, so we'll see it's a real life kind of thing. So background about Dr. Martin is that he 1996 to 2002 was the first medical faculty of the Charles University in Prague. In 2000, he had an elective semester at the King's College London. In 2016, he was in the Regenerator program in the University of Budapest. After graduation in 2002, he worked in dental clinics in Prague and Dubai. In 2010, he co-founded the 3DK Dental Clinic, which is one of the top clinics in Czech Republic. So what like spot on, doc. I hope to come visit it one day. In his professional life, he has focused mostly in implantology, aesthetics, and prosthetic dentistry. In 2016, he successfully completed his regenerator program by Dr. Istvan Urban in Budapest. He's a passionate photographer and investigates the interaction of light and different dental materials. He's a certified member of the Czech Academy of Dental Aesthetics. During his career, he has given many lectures and practical courses on the topics of bone augmentation techniques in dental implantology, soft tissue management and implantology and prosthetics, dental photography, and etc. The lectures and courses took places all around the world. So he is a one-of-a-kind international speaker. So we are very, very honored to have you here today, Dr. Martin, and I'll yield you the floor for the presentation today. So thank you very much.
Thank you very much. It was so long. I mean the introduction. I never thought of myself like so many things could be said even then. So thank you very much for that kind welcoming introduction. I'm really happy to be here with you, and I hope that I will empower your enthusiasm for dentistry, as I understood most of the audience are the young professionals, students and young professionals. So you are right at the beginning of your careers. So I'm happy to bring a little bit to your right to this topic of soft tissues, because I think that it's a really popular topic. It's more and more important. It's definitely a part of aesthetic dentistry, but it's also a lot, even more than aesthetic dentistry. It's the biology that is behind, and it's a really important topic for health of tissues around teeth and implants. And as I know from my times when I studied, we really, when we left the university, I very well can remember how shallow was my knowledge about the relations of soft tissues, teeth, and I'm not talking about implants, of course. But so what I feel like a goal of my presentation, which we have 60 minutes, I think, today. So the goal of my presentation is to bring the rationale of soft tissue biology and relation to teeth and bone, because I feel that there is a lot of predictability that is biologically grounded. And if we understand the biology behind, then a lot of clinical applications will be really predictable for us. So stop talking about the introduction, and I would like to go ahead with the presentation. So we know probably from you, I'm sure that when we had topics of anatomy and histology, we were all educated about these boring terms like such gingiva, the keratinized tissue, mucosa, whatsoever. And it was just a word. I know it very well. It was just a word, and we really didn't understand properly what does that really mean. What is the value of these words for us? And I have to say, the more and more I work as a dentist, I understand how, or I realize how important these tissues are and how much they work for stability of soft tissues around teeth and the health of bone underneath. So let's come to the basic terms first, because I'm sure we really have to understand the very basics of anatomy and histology of the soft tissues around the implants, because that will help us to understand what actually these tissues do for us. So if we begin a little bit with theory, but just only to understand what is the topic about. We see that the tooth is seated in the bone socket. Of course, it's linked with the periodontal tissues. So here we can see the periodontium, which is inside the dental socket, the osteal socket. And this connective tissue is basically going out the bone and giving the envelope also at the outside layer of the bone, which is the periosteum. And on the top of the alveolar ridge, there is a soft tissue lining.
Doctor, I'm sorry to interrupt, but the slides aren't moving.
Sorry?
The slides aren't moving.
The slides are moving?
Yeah.
Okay, I'm just using the pointer.
We can't. No, I can't see it right now. It's just on the first slide.
Yeah. There is a scheme of the mucogingival junction, alveolar crest, and gingival margin. That's what I see here. Can you see the same?
All I can see is the soft tissue management introduction, Dr. Martin, Prague, and just the background. Yeah.
Okay, I don't know why then, because I'm on my second slide or third slide already, so you don't see the presentation is not moving.
No, it's not. If you'd like to connect and reconnect to it, if that would maybe.
Okay.
Yeah, we can see it like that. But maybe.
Okay. So what slide can you see now?
I can see it right now, the mucogingival junction. Can you just move it
Okay.
right or left to make sure it works?
Now it moves?
No.
It doesn't move.
No.
Because my presentation is changing. It moves here. So honestly, I don't know what to do. Where's the problem?
Let
You know
me-
what? I will wait. I will try something else. I will
Sure.
share simply everything, and hopefully it will change. Can you see the slides changing now?
Yes.
You do?
Yes. Yeah.
Okay.
Perfect.
Okay. So again, when I was talking about the importance of soft tissues, I was talking to this picture, right, where we can see the keratinized, nice keratinized gingiva here. We can see the mucosa here. Now you see also the pointer.
Yes, we can see it with the
Okay,
pointer.
great. I love the techniques. You see that that's what we were discussing before. Sometimes the technical issues or technical advantages has also some disadvantages and bugs. Okay.
True.
So let's go to the scheme. Here we can see the bone, the periodontal tissue, the periosteum, and the lining where I stopped. Right. What is important now on the lining that gives us this surface of the alveolar ridge? There is a clearly remarkable mucogingival junction. That's the point where the mucosa, which is lined with the squamous cell non-keratinized tissue and the keratinized tissue. This is the junction of these two epitheliums, and it's usually very well distinguishable. Then, of course, we see the gingival margin, but it's more important to go through more detailed analysis what is in there. We know the terms of attached gingiva and free gingiva, okay? And now, what does that really mean? Because I realized that many dentists, and in my country is very often like that we talk a lot about the importance of attached gingiva, but not really everybody is able to explain what does that mean. So what does it mean? The thing is that the gingiva is formed on the surface with a keratinized epithelium, and this keratinized epithelium has a strong connective tissue in lamina propria, which is the layer right below the epithelium. And this lamina propria is full of really dense connective tissue. And this dense connective tissue is able to link to the underlying structures. And these structures can be either the bone or it can be a tooth. So if we want to talk about the attached gingiva, we need to talk about the lining, which is keratinized. It's one of the conditions to talk about the attached gingiva. And then we need to have some kind of attachment of this keratinized gingiva either to the bone or to the tooth through the connective tissue attachment. So that's this small part above the ridge of the bone So this small part of the attachment is the connective tissue attachment. What does mean a free gingiva? The free gingiva is the definition of free gingiva is more, I would say, unprecise, or is more flexible, let's say, because most of dentists, I realize that most of dentists, and in the clinical practice, it's quite logical that the definition or the margin between the attached and free gingiva is the bottom of the gingival sulcus. So anything what we can find between the sulcus, the bottom of the sulcus, and the mucogingival junction could be called free attached gingiva, whereas the free gingiva is the one which is the keratinized tissue just over the sulcus. But what says the literature? The literature actually says something different. If we go to the literature, I will skip this one. The literature will tell us that that the attached gingiva is only the part of the keratinized tissue which covers bone and the connective tissue attachment. But what about this small part of epithelial attachment? This, by the literature, by the textbooks, if you go to the classic textbooks of periodontology, Linde, Otto Zur, and so on, plastic periodontal surgery, beautiful pink book, you will find that the free gingiva is everything what is attached with the epithelial attachment plus what is above the dental gingival sulcus. And that's quite weird, honestly, in the clinical application, because if I should really find and say how much my patient has the attached gingiva, I would need to make a histological split. I would need to make a section of my patient to find where is the border between the epithelial attachment and connective tissue attachment. And honestly, this does not make really that much sense. And in my clinical practice, I really don't care if my keratinized tissue is attached to the bone, to the connective tissue attachment, or epithelial attachment. And the thing is, I have no straight way of how to really recognize if it was defined as I said. But what is good, or at least I believe it's good, in 2021 there came this nice paper of Dennis Tarnow, who gave us a redefinition of these terms. And I think it's really worth it to read this paper, because what he did, he gave us a new definition of zone of the attached gingiva from the mucogingival junction and the bottom of the sulcus. So everything what is keratinized on the top, on the surface, and what is attached to any structure below, either it is a bone, either it is the connective tissue attachment or epithelial attachment, by this new definition, it is called the attached gingiva. The thing is that once the keratinized tissue is attached anyway, in any sort of attachment, it gives a stability to the marginal tissue. And it's really important to have some sort of attached gingiva. So this is a little bit of change, and why I talk about it so much, because I very well understand and I realize that I'm talking in many many of you are students. So if you go to the examination tomorrow and of periodontology, and you will be asked what is the attached gingiva. So I don't want to give you a bad mark, okay? I don't want to put a confusion into this topic here, and I want to pick up that by the traditional textbooks, the attached gingiva is the keratinized tissue lying over the bone and connective tissue attachment. But by the new definition, and in my perspective, it's better clinical approach. It's either the bone attached gingiva, connective tissue gingiva, and epithelial attachment. Okay. But now let's go to the clinical application. What does it mean? Why is it so important? We have to realize that these soft tissues are kind of the sealant between the outer space full of bacteria. In the mouth, we have saliva. There is hundreds of bacterial stems, and they are more or less aggressive. And they are always trying to go in and invade into the tissues. But on the other hand, there is a bone which needs to be sterile. This is the inner space of our body. So we have to realize that it's only the soft tissues which gives the magic of homeostasis, the protection of the inner space, of the sterile inner space from the outer space, at the place where the tooth, the structure of tooth, penetrates the soft tissues. That's the thing. The tooth is actually penetrating between the inner bone and the outer oral cavity. And the soft tissues, the great function of soft tissues and gingiva is to seal perfectly the environment of body. And there is a strong importance of attached gingiva, of attached tissues, because there is nothing more and less than this that gives us this protection. And if something should work, if something needs to be effective, then we need some minimal range, some minimal effective width of this sealant. And that's actually what the term biologic width says. The principle of biologic width says that if we want to seal reliably the bone, sterile bone, and all these tissues around from the oral cavity, then we need to have at least 2 millimeters of soft tissue attachment. Why? Because if we look at that place more in detail, then over the bone crest, there is 1 millimeter of connective tissue attachment. And the thing is, it's a very old information. It's from the cadavers studies from 60s. In 60s, what they found that any time, any tooth, any surface you check, you will always find approximately 1 millimeter of connective tissue attachment all over the tooth, above the bone crest. What they also found that the epithelial attachment has also at least 1 millimeter height, but it could be more, could be 5, could be 3, could be 6. So there is kind of a variability of the height of the epithelial attachment, but there is never less than 1 millimeter. But there is roughly constant height of the connective tissue attachment. It is just 1 millimeter. And as if the question is how much at least we need, then we need 2 millimeters, 1 connective tissue, 1 epithelial. And these 2 millimeters gives us the concept of the biologic width, What does that mean? That means that anything we do in our office, anything we do to our patient that invades into the soft tissue attachment, and it leaves less than 2 millimeters of soft tissue attachment in relation to the bone crest, then we cause a violation of biologic width. And that is the reason why this term biologic width is so important for us. We need to understand that anytime we invade into these 2 millimeters, we will provoke a reaction of the body, which will either repair the attachment of soft tissues or will lead to bone resorption. I hope it's clear. I really find it fundamental to understand this topic, okay? Why is this attachment so important? Because, as I said, the connective tissue fibers link basically everything to everything. So they link the bone to the tooth as PDL, periodontal ligament. They link the cementum to the gingiva and the periosteum to gingiva. And in this layer, supercrest layer, there is also a system of circular fibers and interdental fibers. And all this net of fibers in the lamina propria of keratinized gingiva is so firm, and it's so important to bring us the effect of sealer and protection between the oral cavity and the inner space. Okay, so that's basically the physiology and anatomy of the gingival margin, bone, and tooth. But in a clinical application, of course, we work with a simplified scheme, which where we don't really need to analyze what's underneath. There is no way of analyzing it. Anyway, we don't have microscope. We simply need to know where is the bone. And in order not to harm the bone, in order to give the gingiva behave predictably, we need to know the relation of the bone crest and the gingival margin. And because we didn't talk about the dental gingival sulcus yet, so if we add 1 millimeter of the dental gingival sulcus to 2 millimeters of biologic width, here we have another term which is called dental gingival complex, and it consists of 3 millimeters as the minimum distance between the gingival margin in our patient and the bone crest. And these 3 millimeters is the range of soft tissues that needs to be given to the soft tissues around teeth. Very simple as that. If we forget everything what I said and what can be said about that topic more and more, this is what we need to know. We need to know we need 3 millimeters of soft tissues between the bone crest and gingival margin. Okay, so that was how it should be. And now let's talk a little bit what happens if it breaks or if we want to change things, okay? So because not everybody has such beautiful tissues. Maybe we have patients who have these bone lock, okay? You can see that in certain cases, the bone is really thin. So it actually recedes under the tissues. So we don't see there is a lack of bone. We just, but it doesn't really mean that if there is no gum recession, there is always a bone. No, it's not like that. And now what happens if the bone recedes? Does it look like that? What is here on the scheme? Well, actually, it does not. It does not, because as we know from the studies, as I was talking about them, we know that the range of the connective tissue attachment is more or less 1 millimeter only, never too much more. So if the bone recedes, it does not look like this. What happens is that actually the connective tissue recedes with the bone. So it's then replaced by the epithelial attachment, which we could say, well, what happens? What's wrong here? Well, maybe nothing. But the thing is that the epithelial attachment is much less stable than connective tissue attachment. So maybe these patients who are having a little bit less bone are more prone to the gum recession, for instance, because their connective, tissues are connected with the less stable epithelial attachment and not the connective one. Okay, so the question now is, what happens to these soft tissues if they cover the tooth, but with a weaker epithelial attachment? How stable will this be? The thing is that the crucial feature of this epithelial attachment and epithelial and soft tissues, which are locking the bone structure underneath, the crucial parameter is the thickness of this tissue and the presence of keratinized gingiva. But the thickness is the crucial aspect of stability of soft tissues in cases of bone defect. So in cases that we have a thin layer of soft tissues, so not even the bone is missing there, but also the soft tissues are thin. So you can feel that in these situations where the epithelial attachment, which is less stable, the bone is not there, connective tissue is not there, the thickness of tissues is not there. These patients are really prone to gum recession. These patients will face a lot of problems with receding gums spontaneously, but for sure, if we give them a dental treatment, we can make filling, composite filling. We can place the retraction cord, and by doing this, we can cause gum recession. So we should really, when we approach the patient, we should be able to read the phenotype, meaning what is the thickness of the tissues. So if we watch this patient, we can see that on the left, it's clear, thick tissue patient. You can see a lot of keratinized tissue here. You can also see the stippling, which are the small dots on the top of the soft tissues. You know, this stippling, what is that? It's basically the fiber connection which links the keratinized tissue to the bottom, to the connective tissue attachment, or to the bone. You can also see a much shallower scalloping of gingiva. On the contrary, this is a clearly example of thin phenotype. So in these cases, you can see there is really a lack of keratinized tissue. There is the keratinized tissue maybe only over the top of papillas here, but look at the margin of the gingiva, or we could maybe somewhere, we should not even say gingiva, because gingiva means keratinized tissue. If there is no keratinized tissue, we should say mucosa. So here, there is no gingival margin or marginal gingiva, there is a marginal mucosa. And the thing is that when we see these patients, we can be sure that there is no bone underneath. And if there is no bone underneath, it means there is no connective tissue attachment. Then there is the epithelial attachment only. And these tissues are really, really very unstable. And we should prevent, preferably, we should prevent touching these tissues with the retraction cords. Anything we do, we will harm it. If you remark, the yellow line is the mucogingival margin. The blue line is the depth of the dentogingival sulcus. So if you consider what is here, there is no attached gingiva at all. No attached gingiva at all. Very interesting. I don't want to put too much studies here, but I really find really interesting this study of Antonio Linares. It's the Spanish periodontologist, and this is one of the series of their studies where they studied what happens if you place mucosa to the margin of soft tissues around teeth, and they compared what happens if you do the same around the implants. And so they did it with the dogs. And what they found that if you place a mucosa, you cut off the gingival margin, I mean the keratinized tissue, and you place mucosa over the margin of teeth. So there is no keratinization here. And you analyze the situation after several months. What they found, that the keratinization will appear again. So it will grow there again around teeth. But this does not happen to implants. The implication of this finding tell us that the keratinization of the soft tissue lining around teeth and implants is basically provoked indicated by presence of, if you want to say bone, you are close, but you are not right. Not the bone, but a periodontal ligaments. If it was a bone itself, then it would also happen around implants, but it does not. It does happen always around teeth. So, because the teeth have periodontal ligaments, but implants don't, there is a theory and a hypothesis, but it's very likely true that the keratinization of soft tissue and creation of the of connective tissue attachment is the function of periodontal ligaments. What does that mean for us? Actually, it means that I will go back here, if you see the patient who lacks the keratinization of gingival margin, that means that if there is no keratinization, there is no periodontal ligaments. If there is no periodontal ligaments, it means there is no bone. So that's why I think we can say and read in a clinical application, it's really important. This what we just explained, it's really important. Because then we know that anytime we see the patient with lack of keratinized tissue, it tells us there is no bone, be careful. There is no bone and there is no connective tissue attachment. And the tissues will really be unstable. So this is what we call the thin phenotype. The thin phenotype will be very prone to what did I do? The thin phenotype will be really easy to create the gum recession. Okay. But what can we do with it? What is the solution? If we have a patient who is having gum recession, can we do something for these patients? Yes. Well, if we want it to be perfect, we would need to, let's say, bring back the bone up where it was, then the connective tissue will creep up and the soft tissues will creep up. The problem is there is no clinical technique, there is no clinical solution how to bring the bundle bone up to the root surface. It does not exist on the buccal surface. So we know that we are not able to bring the bone up to the clinical crown. But what we can do, what we want to do, we want to bring the gingival margin back to the clinical crown. We call it coronal advancement. Okay, coronal advancement of the soft tissues. The problem is that if we just cut the tissue and move it over the root surface, and we leave it as it was, we leave the thickness as it was, it will recede again very likely. So if we want to make a coronal advancement, we need to change the phenotype of the soft tissues, because only if we make the thin tissues thick, then we bring the lost stability of soft tissues. Of course, we will not bring what kind of attachment we achieve. We will not achieve the ingrowth of the connective tissue attachment. Why? Because the connective tissue attachment is always just 1 millimeter above the bone crest. So we will bring the long epithelial connection here, but at least something. And to make it more stable, to bring the blood supply, the nutrients to these tissues, because the periodontal tissue here, which gives a periodontium, brings this blood supply to this tissue, is far away. So we need to make it thicker. And here you can see the clinical application. Here is the patient, where you can see on the upper pictures, you can see the gum recessions. These patients usually have two problems. They have the aesthetic reasons why they want to solve it, because they don't like the receding gums from the aesthetic point of view. And second problem they have some seizures for on air and so on. So what can we do for this patient? If we want to bring the gum down to the crown, we need to make it thicker. So there is one more thing that we should also look at. If you look at the shape and position of these teeth, you will see that this patient has a very prominent teeth to the buccal aspect of her, as a lady, of her upper jaw. And one of the things that is really a negative factor that brings everything even worse is the protrusion of teeth. Because once the teeth go out of the bone envelope, they make the bone even thinner. And as the thinner bone recedes, the gum recedes. So one of the factors that needs to be solved, or that should be reflected, is the position of teeth, and maybe reduction of the prominent roots. One more thing here you can also see there is a loss of a natural cementum enamel junction. You can see the obstructions that this patient has, which are mostly related to her orthodontical disturbances and bite, traumatic bite. So at this side, I will show you some first pictures and then some video. I hope the video will work. So what we did, we first changed and restored the shape of the cementum enamel junction. So we did a composite filling to create a natural shape of the cementum enamel junction of her clinical crown. And one thing, because I'm sure that not everybody will do the surgery, okay, but all of us are doing fillings, and we all do. We all treat the obstructions. So one thing from the restorative point of view, not from the surgical, but from the restorative point of view, if you are doing fillings to the place where you need to restore the obstruction, look how is the shape of the clinical crown. And it, by the way, isn't there this what we call emergence profile? Isn't that missing? One of the mistakes that we could do is that we just make the filling which is flat. If we make it just flat, what happens if this patient bites? You can imagine what happens to the food, because these people are eating, they are biting, and the food comes over the clinical crown. And if this filling is flat only, the food actually hurts the gingival margin. And what happens to the margin if it's a thin phenotype? You can imagine the traumatization to the thin phenotype with teeth which are locking this bulky cement-to-enamel junction are harmed even more. So from the restorative point of view, what we can do for these patients, if we restore the teeth, let's do the fillings with this shape. So there is the emergence profile, which is emerging, it's divergence from the root to the clinical crown. Then because we said we need to make the phenotype thicker, we need to harvest the connective tissue graft. We need to place it underneath the soft tissue. So in the surgical point of view, we prepare the split thickness flap. Then we place this connective tissue graft inside to make the tissues thicker. We need to release them from the muscles, from the elastic fibers, which are in the subepithelial in submucosa. And then it allows us to make the coronal advancement of the gingival margin. But because we made it thicker, it will be also stable. Regardless, there is no bone and there is the epithelial attachment only. So this is the result on the left side. Let's go to the right side. I hope the video is running.
Yeah, it's running, doctor.
Perfect. So here you see in more detail what we need to do during the surgery. Because the teeth are prominent, we need to scale the surface of the root. There are basically two reasons why we scale the root surface. First reason, we simply need to remove all debris which is on the top, because there can be a calculus, there can be a plaque, there could be some restorative material. So the surface of the tooth must be really perfectly cleaned, so it is able to accept the new epithelial connection of the graft that will be advanced on top of this tooth. And there is the second reason why we do it. The second reason is, as we said, the position, the malposition, the protrusion of the tooth is also one of the features that's negative. We also want to reduce a little bit the pressure of the tooth on the soft tissues. So after scaling the surface, we have air braced the surface just to make it a little bit rougher and perfectly clean. And here you can see how I do a renewal of the cementum enamel junction. So I really try not to make this restoration flat. It's really my belief it is a mistake. So I'm simply restoring what was there. You know that the cementum enamel junction is not flat on the tooth. There is this convexity. It's just like a layer of enamelum which is on top of dentin. And this has basically several advantages. One of the advantages, as I already described, is the protection for the chewing, the masticatory protection for the food that is going over the clinical crown. So I know that if I make this bulky shape of the cementum enamel junction, I am going to protect the soft tissues underneath. There is one more reason why is it important. As the pressure of tooth given by the shape of a tooth, it is the factor that leads to gum recession. We can employ this behavior. We can use it. We can give the shape to the soft tissues by shaping the clinical crown. In other words, the shape of gum is given by shape of tooth. So if we shape properly the clinical crown, we can expect the correct shaping of gingival margin. Because during the surgery, we need to bring the soft tissue graft, we need to harvest it somewhere. There are several techniques how to harvest the soft tissues from the palate, or mostly from the palate. It's not necessarily the palate, but the hard palate is the most frequent and most effective place where to harvest the soft tissue grafts. This what we see here is something that is called a superficial connective tissue lateral palate superficial lateral palate graft, which means that we harvest the epithelium with lamina propria, which is right beneath the epithelium. That's why it is superficial connective tissue graft. This technique was described by Giovanni Zucchelli, and so sometimes it's simply called a Zucchelli technique. So we first harvest the proper size and shape of this tissue by complete excision of epithelium and lamina propria, which is right underneath, because it consists of the very dense connective tissue. And then after it's harvested, I will just skip it a little bit. After it's harvested, we of course need to de-epithelize this connective tissue. And here you will see how thin is the layer of epithelial tissues. The thickness of this epithelial tissue ranges between 300 microns to 600 microns. So that's also the reason why other techniques which elevate a thicker layer of epithelium at the end are just wasting a lot of subepithelial connective tissues because the layer of epithelium is really, really thin. And the problem is that the layer of lamina propria is variable, and in many cases, it's not that huge. There is always 1 millimeter of connective tissue under the epithelium, but some people have it, some people have more, some people have 1 millimeter only. So one of the advantages of this Zucchelli technique is that using this technique, we know that we will be able to harvest the connective tissue in 100% of patients, because every patient has 1 millimeter of connective tissue under the epithelium, every. So this, here we have the connective tissue ready. We can just clean it from the adipose tissue, which is in the submucous layer of a heart pellets. And we don't need that one. And here we'll see the surgical technique, how to create the space for this soft tissue graft. Again, there are many techniques how to make the how to proceed the gum recession treatment. But here, what we can see here is the technique that is called the tunnel technique. The tunnel technique, which was developed by Otto Zur and Professor Hulzeller from Germany. Basically, we use a split thickness flap, which is created by this very useful knife. You could see at the beginning that you can bend it, so you can twist it. So it's really very nice surgical instrument, very handy. And this part of procedure is very peculiar. We really need to be careful because there is no releasing incision. You can see that all the approach to the soft tissues is right from the dental gingival sulcus. So we really split everything from the sulcus. We release it from the fibers of muscles, fibers of elastic fibers in the fornix. And the goal is to make this soft tissue cover free to move. And when it's free to move like this, we can do the coronal advancement. But as we explained before, that would not be enough. We can stay with the coronal advancement only if the thickness of tissues is good, if it's sufficient. But most of patients basically don't have enough of soft tissues, luckily, because the thick tissues are the reasons of their gum recessions. So in most cases, we do the thickening of soft tissues. And here you can see the maneuver, how to bring the soft tissue graft inside the pocket. Into the tunnel. And that will basically change the phenotype of the soft tissues. From the thin to the thick. And now you can see that the graft is partially exposed. There are some techniques and approaches where we can leave the graft partially exposed, but primarily we are trying to cover it with the soft tissue lining. So it's completely hidden into the tunnel, which is much safer because the gingival margin or the soft tissue cover is the only one tissue which gives the blood supply and nutrients to the free tissue grafts. So, because this tissue graft has no blood connection during the few first days, so there is only the osmosis which is reliable for the ingrowth and income of the nutrients. And here you can see the result, how the recession was covered on at the right side. So I want to pick up that in most cases, in many cases, it's not only just bringing the tissue down, but we need to make change the phenotype to make it thick, and we also need to check whether the position of teeth are not too buccal. In certain cases, we could, if the protrusion of teeth would be so huge, then we cannot simply solve the gum recession by surgical approach. We need to first solve the malposition of teeth. So the primary treatment for those patients could be orthodontical treatment. And interestingly, just by bringing the tooth to the correct position can solve the presence, or can solve the gum recession themselves. And the final point to this clinical application, even if you are restorative, don't forget that the shape of our restorations can really give us a stability to soft tissues. You can see this convexity makes like a balcony that protects the soft tissues underneath. This relation between the shape of the crown and thickness of soft tissues is really, really important too. You can see the before and after. Okay. Okay, so that was briefly to the topic of gum recessions. There is another, I can see it's 7:05. I don't know how much time we still have. If I can go farther or I'm done, you tell me. I'm okay. I can go ahead. Is it all right? I go ahead.
Hi, doctor. So you have an extra presentation that you would like to give, or slides that you would like to add?
Yeah. Because you know what, I think we finished the first part of it, which is the gum recession. Okay. I also have 2 more cases to talk about. If we have the abundant tissue, like if we need to make a gingivectomy.
100%. Yeah,
okay.
we can go forward, doctor. Yeah, 100%.
Okay.
To give it a full approach.
Okay. Okay, so because the first clinical situation was the lack of tissues, here we have the opposite. Okay, we need to make a clinical crown lengthening because there is too much soft tissues. And if we explain it on the scheme that we described before, here we have too much soft tissues covering our clinical crown. Okay, but the thing is that the level of bone and connective tissue attachment is still normal. So we simply have just too much of epithelium and epithelial attachment with soft tissues. In these situations, what can we do? We can just cut the soft tissue. That's very easy. The question, did we interfere with the biologic width in this case? No, because if we simply cut, as it is here, the abundance of tissues, we didn't violate the biologic width because there is still 2 millimeters for epithelial and connective tissue attachment. nice case describing this situation. This is the patient who came with really ugly crowns, and this lady, she wanted to change the crowns, but because not only the shape but also the length of the clinical crowns was wrong, so we wanted to make the crowns a little bit longer, and for that we need to make crown lengthening and gingivectomy in this case. So you probably do gingivectomy as a very simple procedure because it's very frequent surgery that is needed for crowns, for restorative job, for many clinical applications. So you probably know this instrument, but I want to say that what is really important in every situation to make at least a small aesthetic analysis, because it's really easy to make a wrong cut. And one thing is to make it clean. The second thing is to make it symmetrical. If we want to make a symmetrical gingivectomy around 2 teeth in the front part of the jaw, it's very easy to make a mistake. So I want to give you a hint how to make a very simple surgical guide for your gingivectomy. You can use the resin. This blue stuff is a Luxabite. It's for bite registration, but you can also use a bismuth acrylate resin for temporary crowns, for relining technique. And what you do, you just place this acrylic or this resin over the arc of teeth. If you don't have a wax up, that's the best. If you have a wax up, you do it on the model cast. Okay, you do it on not in the mouth but on the model cast. If you don't have a wax up, you still can do it very easy way in your office. So you make this shape from 5 to 5, from left to right, and then you remove it from the mouth, and you then take a pencil and you draw a line how you want to reduce the range of the gingiva here. You can see the line, and you do it symmetrical. Now you can easily do it symmetrical, and then you take a burr and you simply burr out. You remove the excess of the acrylic. So when you bring it back to the mouth, you can clearly see the gum that needs to be removed. The great advantage of this technique is that it covers the gingiva that needs to be saved. Whereas if you take a surgical guides that cover the teeth and they just leave the margin, they cover the teeth, what they make, they give you the approach to the gingiva that needs to be saved. So if you do a mistake by hand, then it's really a problem. So here you will see how it works. So here we have this simple surgical guide. You don't need any special for it. You can do it in 10 minutes on the dental chair. And here you can see that it simply covers and protects the gingiva that needs to be saved, and it shows you only the gingiva that needs to be removed. And one point, just a note to how to work with this high frequency electrocauter. You can see that you come to contact with tooth. Some dentists are like afraid of touching the tooth. No problem, please. That really, it's not a problem. You cannot harm a tooth by touching it. First. Number two, you need to move. If you go too slow, then you bring too much heat to the tissues and you will make a blister. if even worse, you can coagulate the connective tissue which is underneath. Here you can see that after removal of the burned tissue, there is a beautiful, healthy, and vital tissue right at the margin of the tooth. So it's clear that this tissue will heal. It will over epithelize very easily, and this gingivectomy is there is no risk of further gum receding. The reason why the gum recedes even more, because here, why I do so extensive gingivectomy, because the abutments were covered with the gum. The crowns were so there was such a misfit of crowns that the soft tissues actually grown over the preparation, the chamfer preparation of these two pillars. So when we wanted to restore it, we first needed to remove the gingiva all over, but you can see that the tissue is nice and healthy. And now one thing, what would you suggest if you just make a gingivectomy, and so you bring it to such a I will go back here. If you make it so thick as you can see here, and you just leave it, what happens? What happens from the thickness of this connective tissue here? The tissue will grow again. There is very, very strong reparation potential of soft tissues. So if you don't block the growth of tissues, you will face the relapse. So what is really important is to, again, what I mentioned to the filling, you know the term emergence profile. So here it's also important to make a correct emergence profile of our crown. So I will try to paint it. The crown needs to have this emergence profile of the margin. Why? Because the tissue that is cut over will be stopped with the thickness of the crown. If you cut the gingival margin, but you make a crown that will be just blunt like this, you will see a relapse of the soft tissue growing over this prosthetic work. So this is one of the really, really important features of temporaries, that we have to shape them properly in the subgingival zone. And it heals perfectly. You can see here, this is just one, like 10 days, maybe 12 days after the surgery. This is how it looks in the smile. This is after father healing. This is where we did the final impressions for the final crowns. This is the soft tissue integration with temporaries. Then we do retractioning of the gingiva with the cord. This is after the procedure. Another healing. And this is the final crown, a final restoration. And here you can see what I was saying before. You can see how is the shape of the crown. You see that there is a emergence profile, which is not straight, just flat, but it's so much convex to block the gingiva to relapse and grow where it was before. This is important feature of prosthetics, especially to the people who have thick phenotype. These are the crowns cemented, and this is after the integration into soft tissues, and the final result. And the shape of the gum is given by the shape of prosthetics. And again, the integration. So the conclusion of this, we need to understand that there is a strong reparation potential of soft tissues. They're not always the bad ones who want to recede, but they also tend to grow again, especially to the people who have thick phenotype. And what we must not to do, we must not interfere with the biologic width, that's for sure. We need to leave at least 2 millimeters for attachment of soft tissues between the bone and the depth of the dental sulcus, that's for sure. But still, on top of it, in thick phenotype, the tissues want to grow over again. And if we want to block them, then we need to work properly with the prosthetics or restorative dentistry. It can be the filling or the crown that needs to be shaped properly, because that will be the blockage to the soft tissues, that will give it the shape and that will hold it on the correct position. Okay, and the last topic, what if we have so much soft tissues here? So the crown is too short, clinical crown is short, there is too much soft tissues, but compared to the previous patient, there is also too much of bone underneath. What if we do just a gingivectomy as we did before? What we do is the biologic width violation. If we cut the soft tissues like this, then we actually interfere with those 2 millimeters for soft tissue attachment, and we will simply violate the sealing function of soft tissues. And what happens if we violate the sealing function? Well, the biology says it clear. The bacteria will integrate with the soft tissues. They will bring the inflammation, the infection of soft tissues, and the result will be a chronic inflammation of bone margin. And as the result of bone margin inflammation can be, it is the bone resorption, if the bone is thin, or a chronic inflammation, pain, soreness, bleeding, if the bone is thick. So that's the reason why anytime we make a clinical crown lengthening, we should not just cut the soft tissues. We need to understand there is something called bone underneath, or could be. And in those cases, we need to do what we call bone sounding, meaning that when we do this gingivectomy, we need to sound with a gingival probe how far is the bone crest. And if we measure that between the newly formed gingival margin and bone crest is less than how much? 3 millimeters, because that's our dentogingival complex. Sulcus, epithelial attachment, and connective tissue attachment, we need 3 millimeters. If there is less than 3 millimeters, we need to do bone removal. We need to do ostectomy. We need first to remove the excess of the bone, and then we can make the restorative phase of the surgery. So this is the case, typical case for this procedure. Patient with usually a thick phenotype and a lot of abundant soft tissues. You can see there's also a lot of keratinized tissue and what we call a gummy smile. So for these complex and comprehensive treatments, we really need to put a lot of effort to the facial aesthetic analysis. We need to analyze what's the final shape of teeth, what is the final position of gingival margin. That's why we do a virtual or wax up, digital wax up or wax up, standard wax up. In this case, which is the old case, we did the standard wax up in the lab, from which we converted from wax up, we have converted to mock-up. So mock-up shows us what is the range of new gingival margin, and or on the contrary, a new range of clinical crowns, and we clearly see how much soft tissues we need to remove. But of course, we need to check where is the bone, and if we interfere with the bone, or and the distance between the newly formed gingival margin and the bone is less than 3 millimeters, we need to use the ostectomy. Again, there are several techniques how to make the ostectomy. It can be much less aggressive than here, what you see, but the classical approach, let's say the standard approach, is the open ostectomy, meaning that we elevate the flap, we remove the excessive amount of bone just to newly form the bone margin, so there is enough space for soft tissue attachment. This is what you see. The surgical guide shows me the range of the clinical crowns, and I need to leave 3 millimeters of root surface to accommodate connective tissue attachment, epithelial tissue attachment, and dental gingival sulcus. So if the patient has a lot of keratinized tissue, we can simply do a gingivectomy. That's okay, but we should not remove the full range of keratinized tissue. If we want to be more conservative, we just elevate the flap, so we leave the keratinized tissue, but we just move it apical. So if we talked about a coronal advancement of flap to the gingival recessions, here we are talking about the opposite. We are talking about the apical advancement of flap. I will just move it a little bit faster. So we carefully elevate the flap. And then by using the rotational instruments or hand instruments, we remove precisely the necessary amount of bone. We should never touch the surface of the root with rotary instruments, because we don't want to bring any damage to the root. So here you can see a hoe. Hoe is a very nice instrument. It's a scaler which can be easily used for removal of the excessive bone, like this, as you can see. And in cases that the bone is too thick, then we use the rotary instrument, but just to make it thinner. And the last layer of bone is then removed by a hoe scaler or a scaler, standard scaler. If we use piezo or any sort of ultrasonic scalers, it's also possible, but still we should be careful not to touch the tooth surface. So there is no cementum harm. So with this, we measure how much space we have. If we are happy, we are done. After the surgery, we just suture, and we can make temporary. And here you know what I did, because the shape of the gum is given by the shape of the prosthetics. Even though we removed the bone, there was still abundant amount of keratinized gingiva. So after 3 months of healing, we did the gingivectomy, again with this simplified surgical guide to give it a shape. But because we don't want the gum growing back, because there is always the strong potential to grow back, we need to make a temporary that will block it. So here what I do is just relining of the temporary, which was 3D printed. That's what we call the actual temporary, which means that the 3D printer has printed just a scallop, just a like a shell of the clinical crowns, and here we reline it. And after relining it, we create the emergence profile, which will block ingrowth of soft tissue back to the defect. So removal, then we adjust the shape of the temporaries. We need to polish it, shape it, stay precise. Important thing is we really do not need to make a final preparation at this point, because we just need the soft tissues to heal. So it's not necessary to make the final preparation. We can do the vertical preparation. If we plan to make a chamfer preparation, we can do it anytime later. It's not really necessary to do it at this place. So here you can see after the gingivectomy, and this is after 2-3 weeks later, where the gums are beautifully healed and the teeth are ready for the final preparation and final impression. So this is after the final preparation. This is the soft tissue impression. This is what you already saw in the video. And then again, the temporaries that have not just the shape of the crown, but the shape of the emergence profile, which is simply a functional feature of temporary. And that needs to be converted to the final. So even the final restoration have the emergent profiles that corresponds to the temporary, and it gives the gingiva the shape that we achieved and that we planned. Okay, so that's what I wanted to say. I wanted to go through the variables of soft tissues. So to describe what we can basically meet, we can meet the thick and thin tissues, but there is not it's not roulette, if I would say like this. It's not the accident if the soft tissue recede or relapse or grow over. It is a consequence of biology that is behind, and I hope that I managed to bring a little bit insight into that topic, and hope you enjoyed. Thank you very much for your attention.
Thank you so much, Doctor. Honestly, it's been amazing. You really covered it all. You really did. I mean, especially the part where you continued really brought everything into perspective. Like I can actually see if this presented and this case presented, I would imagine what I would go for. So thank you very, very much. And thank you for the cases, and thank you for the videos and the details. It really, it really made more sense than just theoretical, and especially the part where you broke down what each of the definitions are and how to call it and
Yeah,
how to
but
properly.
on the other hand, you know, I really think that it's important not only to show cases, because cases without understanding the little bit of boring theory.
Exactly, which you did at the beginning. You really explained, not in a boring way, to be honest. You really did it in a more clear and to the point. So thank you very much, though, Doctor. Thank you very much. And we have a lot of questions. We actually have a lot of questions. So to start off with, we have a question from Mariam. She said, according to the case in the video, which was the first one, the first video, why the implant part that is shown wasn't covered as well? And the continuing to the same case, she asked, and could we have done a tunnel technique as well in such cases, or since it's an implant, it wouldn't ever be of a good outcome?
Yeah, that's a great question, and it's really a good question to the patient, right? Of course, you know, we should. If I convert the question, what is the indication of thickening the phenotype? And if we talk about teeth, it's actually the sensitivity of teeth, or it is the aesthetic outcome that's unfavorable. That's why we did it to those teeth. We didn't do it for biological reasons. If we didn't do it, the patient would live with those teeth for the rest of her life, and she wouldn't have any troubles. Okay, there is no must indication for gum recession surgery. That's what we should say. Okay, so it was purely the aesthetic reason here.
Concern.
But of course, that's not the answer to the implant side. At the implant side, we also talk about the biologic width of the implants. We also talk about the necessity of thickness of tissues around the implants, and it's a very, very complex issue. So the implantologist need to know how to analyze the amount of bone. He needs to place the implant very precisely into the bone in relation to the future shape of the crown. And here, that was the main problem of this implant. The implant was not placed correctly, but which in the end had as a consequence was this unfavorable shape of the emergence profile and prosthetics on the top. However, there was no inflammation, the tissues were stable, but there was no issue of aesthetics in this case from the side of this lady. So that's the reason. There was no aesthetic indication, and honestly, it would be much more complex soft tissue augmentation to bring those soft tissues up. It's really a different level of soft tissue augmentation to bring the soft tissues around the implants compared to teeth. So the clear answer to this question is there was no need for it, aesthetic need for it, and that's why we didn't do it.
Thank you, Doctor. So we have another question. She's asking, what dressing does the doctor use to cover the donor graft site?
You probably noticed in the video we have used an acrylic splint that covered the palate, which is one of the options, and it's my favorite nowadays. So I just make this palatal cover prior to the surgery, and after I harvest the palate, I just bring there this splint without any suturing. I don't place any materials, any sutures, nothing. I just cover it with this splint. It blocks and then covers the blood coagulum there, and it reduces a pain and postoperative troubles of the patients a lot. So that's one of the options.
Okay. So another question asks, which is coming from me, because I saw that, can we use fillers to fix the black triangles, especially in cases of recession? Is that possible, or is it not favorable, or is there an indication to it, or it's not really?
The indication, for sure, there is the indication, the aesthetic indication, because that's, of course, people who have black triangles sometimes really suffer from it, especially if their mobility of their lips is high. So they show basically these black triangles. Then it might be a problem, but as well the solution might be a problem because we didn't go to that detail, but of course coverage of the gum recessions can be divided into several classes. And the situation when we have the black triangles usually means that there was a loss of the interdental bone peak. And that's the worst. That's the worst situation. So bringing the soft tissues on the buccal is the easiest. That's what we have shown here. That was the easiest situation. If we are facing the patient with black triangles, with the loss of interdental bone peaks, that's the other end of the spectrum. That's the worst. And for sure there is the indication, but I'm not sure there is always the solution. So the surgical solution of black triangles can be tried, but not always with a predictable result. It's the hardest one. And
the surgical, not the fillers.
Yes, the surgical is the hardest one. So what we usually do, we can improve, we can try, we can increase the height of the soft tissues in the approximal spaces with some level of success. But in many cases, in many situations, we need to change also the shape of the crown. So we do a buildup of composite resin to make the approximal contacts longer to the reduced papilla height, or we place a crown or whatever kind of restoration. But it usually needs a combination of surgical approach and prosthetic approach.
Okay, thank you, doctor. We have another question. 1 second. How can we know when in gingivectomies that we don't cut too much of the gingiva, then there will be a recession? So how far a recession? So basically, how far into the gingivectomy of cutting into the tissues, into the mucosa, do you know that we cannot pass this point, or else there will be a recession as an outcome?
Okay, good question. Well, you can count with me, okay? If you go, you know what? I will just to answer. I will go back to this scheme. Because there is the answer. If we want to have at least some attached gingiva, that's what we want, okay? We want attached gingiva. And you know that there are structures that need to correspond. We need to have the keratinized tissue on the top, and we need to have attached keratinized tissue on the bottom. There needs to be an attachment. The most stable structure, if we conclude epithelial attachment, connective tissue attachment, and bone attachment, the most stable structure is the bone, okay? The less stable structure is the connective tissue attachment, and the least is the epithelial attachment. So if we talk about the minimum range of tissues, then we know that we need 1 millimeter for the sulcus, 1 millimeter for epithelial attachment, and at least 1 more millimeter for keratinized gingiva that will be fixed to the connective tissue. So this is 3 millimeters altogether. And still, if we have 3 millimeters of keratinized tissue, still it is not connected to the bone, but to the connective tissue only. You got me? So when we do a gingivectomy, in other words, we are cutting off the abundant amount of keratinized tissue. We should not reduce, we should always reduce it only to that level that the rest of keratinized tissue will be 3 millimeters. If we reduce it more, then we will have a keratinized tissue, but it will be not attached. It will not be attached to the stable structures, which is the connective tissue, attachment, and a bone. Okay? In those cases, if we need to reduce more than that, then that was the chapter that I did not go through that, but in those cases, we should not do a simple gingivectomy, but we need to do an apically advanced flap. We need to raise the flap and move it apically. So the range of keratinized tissue that is at the place is still used, but at the another place. Okay, so that was the long answer, and now the short answer is don't leave less than 3 millimeters of keratinized tissue.
Thank you, and thank you for explaining why. I mean, you could have said, like, honestly, the understanding why is more important than just the guideline, because it helps. It's because you're a dentist, so you can actually think, why are we doing this? What's the reason? So
you can cook with a recipe.
Yeah.
But we should not treat people with a recipe.
Yes, exactly. Because everyone has their own taste, so it's each of the cases different.
The problem is that the taste of biology is sometimes very constant.
True. So we have we have two more questions. There's question is what was the correct shape of the temporary restoration after the gingivectomy?
What was what?
What was the correct shape of the temporary restoration after the gingivectomy?
So you mean the emergence profile of it?
Yes, I think that's what she meant.
Okay. So the thing is that I will try to paint it here. Wait. So the thing is that you have a tooth, you have gum, and you did gingivectomy. So you have this level of gum, okay? And you want to prevent the gum going back to this place. So we will do a temporary that blocks the soft tissues in its overgrowth. So we need to, we need to do the emergence profile and then continue with the shape of the crown. Sorry for my painting, it's terrible, but I hope that it's clear what I want to say. So one thing, the thickness of this crown here corresponds to the thickness of soft tissues. Okay? The second thing is, how is this angle that emerges from the tooth to the surface? And my recommendation is 60 degrees. This angle. Do you know what I mean? The angle.
Yeah, I get what you mean, doctor.
Yeah. So it's not 90 degrees, it will be too much. But if you do it 60 degrees, it will create a nice emergence profile, and it's still very well cleanable, let's say, and it blocks the soft tissues. It doesn't mean that you necessarily have to transfer it to the final restoration. Okay, the final restoration can be milded a little bit then. Okay, because what will happen that as it maturates, it can also happen that the soft tissue in the future will do like something like this. Okay, so in the future you don't need so aggressive emergence profile with the as with the temporary, but for the temporary 60 degrees.
Got it. Thank you, doctor. So we have a last question, which asks, for the guide, is it a polyether putty automix, the material that was used?
I will show you, wait. So the material that I used was this one. It's Luxabite. You can have it in the cartridge, in the pistol like this. So you just place it into the pistol, and then you put it on top over the teeth or on the cast. Okay, if you have your wax up, if you have a model like this, you just place it over the teeth, over the gums, more over the gums than the teeth. Okay, because it's stabilized on a gum surface, not on a teeth surface. Okay, and you can use this Luxabite, or you can use just bismuth acrylate, like ProTemp,
so it's a bite registration material.
This is a bite registration material.
Okay.
But what you need it to be, it must be hard. Doesn't matter what it is. The thing is, it must be hard.
Okay, got it. Okay, perfect. But I have to say that a lot of, like, I have to read out, honestly, one of the nice messages that she says, Herta says, this was amazing. I have a lot of notes and a lot of papers to read and look into. Thank you for the details and explanation. Loved every part of it, and I fell in love with the subject. So thank you, Professor. So we have a lot of messages of thanking you and telling you how amazing it was. So thank you so much, Dr. Martin, honestly.
You're welcome.
Thank you. And yeah, thank you for every detail. Thank you for really covering everything and answering all the questions in full detail and showing us the exact things you use in clinic. So it was truly, truly amazing. We would love to take a picture, a screenshot of the picture to commence this this webinar. So yeah, will you take the picture?
So yeah, sure. Yeah.
So who can switch on the camera? So guys, please join us for the picture.
I never did it.
Well, that's a new thing.
I never did a group picture. The picture of the group of people online. My God, this is crazy.
Let's do it.
This is the digital dentistry, right?
Yeah, that's the way. That's a new era for dentistry. From all around the world, basically, because we've got people all from Malaysia, India, Egypt. I mean,
that's
it's just
wonderful.
Latvia.
Hello, everybody. But Malaysia, you have a midnight. You have 2 o'clock in the morning.
So they can answer to that. I don't. Yep. I think she.
At least 6-7 hours in advance of us.
Because your lecture is that important, doctor.
Yeah, it's 9 o'clock here, evening.
9 o'clock in the evening.
Yeah.
Okay, so it's not that bad.
And I was driving.
You were
this
driving.
was amazing. Thank you.
Ah.
Yeah. Yeah, but this was amazing. Thank you. Thank you. I fell in love.
I'm
Yeah,
happy.
I know what I'm gonna study now.
Good. Soft tissues are really enjoyable topic.
Yes.
Okay.
Thank you.
So everyone is ready for the picture? Okay, so
Yeah.
let's go for it. 3, 2, 1. Smile, guys. All right, perfect. We have it. Thank you.
Perfect. Thank you. Thank you, Dr. Martin. Thank you very much. And thank you for everyone for attending today. And please fill in your forms to get your certificate. So you'll send them by the end of the month. So thank you very much.
Dr.
Thank you.
Martin, thank you so much for an amazing webinar. I'm
Thank
reading the feedback form and I'm impressed a lot with a lot of positive feedback. So thank you so much for imparting them to students worldwide. And I truly appreciate we took from your time 2 hours. So really
Yeah.
appreciate it.
I will
And
tell you a secret. I'm never on time. I never end up on time. Never, ever. Never.
thank you
I
so
think
much.
it's a dentist
And
thing. We never have even our
true,
procedures. Our procedures never take just 30 minutes or 45 minutes. They always go over time.
true, and hope to see you soon.
Hope to see you
My
soon.
pleasure. Have
Thank
a
you.
great time. Have a great evening or morning,
You too.
wherever you.
You too.
You too.
Bye bye.
Bye.
Bye
Thank
bye.
you very much. Bye-bye.
Thank you, everyone. Have a nice day.
You too.
Perfect.